Radial nerve injuries are going to present with wrist drop. What is wrist drop? Wrist drop is loss of wrist extension. Loss of wrist extension. Okay. What else will be there? There can be finger drop also. Finger drop. What is finger drop? It is loss of finger extension. Loss of finger extension where? At the MCP joint, which is the knuckle joint, and metacarpophalangeal joint, and also the interphalangeal joint. Interphalangeal joint, yes. Are you sure about that? This you have to discuss. Is there a loss of IP extension or not? Because MCP extension will be lost, that is understood, that is called finger drop. Finger drop is loss of MCP extension. But what about IP? Is it working or not? See, it is radial nerve injury, not the median nerve or ulnar nerve. It's still working. And because they're still working, lumbrical interosseous is still working. And because lumbrical interosseous is still working, they can still do interphalangeal extension. So understand. If there's a radial nerve injury, as you are suggesting, there will be a wrist drop. Of course, wrist extension is compromised. Finger drop, but it is loss of finger extension and MCP joint, not the IP joint. Why? Because IP extension is still possible. How? Because it can be done by lumbrical interossei, which are supplied by medial ulnar nerve. They are still working. This is a case of radial nerve injury. But how the lumbrical interossei do interphalangeal extension? By inserting on dorsal digital expansion. Remember? Maybe extensor digitorum is not working. Maybe. But these muscles are inserting. They can still work. So IP extension possible? Yes. In radial nerve injury? Yes. Remember that. As you say, so wrist drop is a feature of radial nerve injury? Yes, not necessarily. Why not necessarily? Let me show you some diagram, some question first. So what is this? Actually, as you know, the radial nerve is supplying the dorsum of the 3.5 fingers, so minus the nail bed. If you are talking about these sensory loss, it will restrict to the middle phalanx, proximal phalanx, especially the dorsum of the first web space, because dorsum of the first web space is exclusive to radial nerve. That will be sensory loss. But the nail beds may be still having sensation because of medial nerve supplying the distal phalanx area, nail bed area. So only this area involved? Yes. Sensory loss? Yes. And there is a finger drop and wrist drop. Yeah, but wrist drop is not necessary all the time. Why? Because see this question, there is a finger drop with no wrist drop, but this is still radial nerve injury. But how can this be radial nerve injury? It is a branch of radial nerve which is compromised. Which branch? See, finger drop means loss of MCP extension. MCP extension is gone. So there is a finger drop. But IP extension may be working. And wrist drop may be, wrist extension may be working. But how? What is this injury? It is actually a branch of radial nerve. But how can you explain it? Explain it? That will do, but I'll ask a question to you. Will there be sensory loss in this patient? And you will say, no. Why? Because it's a pure motor nerve. It's a pure motor nerve. It will not present with sensory loss. So, B remains the answer, but why B is the answer? We have to find out. You have to draw a diagram for the radial nerve telling posterior cord of the brachial plexus in the axilla, will get the radial nerve in the axilla, will passing behind the bone humerus in the radial groove, come out of the groove and reach front of the lateral epicondyle and keep supplying some muscles there. What muscles it was supplying? It is supplying the triceps muscle in the groove and also anconeus muscle in the groove. And what else? It will come out of the groove and supply some ECRL muscle, extensor carpus radialis muscle, along with brachioradialis muscle. And then what it will do? It will then divide into two branches. One is motor nerve to supply the posterior forearm muscle called posterior interosseous nerve. So dividing into motor nerve, posterior interosseous nerve supplying posterior forearm extensor muscle. Yes. And then it is giving a cutaneous branch, and that cutaneous branch You will see that is the cutaneous branch which is coming to the dorsum of the first nerve space. Dorsum of the first nerve space. At the roof of an artificial nerve box, it will pass and supply dorsum of the first nerve space, and also, of course, it will supply 3.5 fingers skin minus nail bed, because nail bed is median nerve. So this is the diagram which we are supposed to draw. You are looking at the right humerus lower end once again. This is the right humerus and lower end of the right humerus again. This is the lateral epicondyle. So that is the lateral epicondyle once again. Yes, you are talking about the posterior cord of brachial plexus in the axilla, giving you a nerve which is continuation of the posterior cord, and we call it as the radial nerve. This radial nerve is passing behind the bone humerus, and then you can tell that it is radial nerve in the radial groove behind the bone humerus. Then it will come out of the groove and come in front of the lateral epicondyle, become a content of the cubital fossa. And in the cubital fossa, it will be giving two terminal branches. One of them is cutaneous. That cutaneous branch will be actually going to the roof of the anatomical snub box, and then it will supply 3.5 fingers on the dorsum of the hand, but minus the nail bed, minus the nail beds. So you're telling that this is the posterior cord of brachial plexus in the axilla. Yes, in the axilla. And then this posterior cord of brachial plexus in the axilla continue as the radial nerve in the axilla. Yes. And this radial nerve is passing behind the bone humerus, radial nerve in the radial groove. Yes, come out of the groove and come in front of the lateral epicondyle. In front of lateral epicondyle, it will give two terminal branches. One of them is the cutaneous branch, which is at the roof of an artificial snub box, and supplying the 3.5 fingers on the dorsum of the hand, minus the nail beds. Yes, because nail beds supply the median nerve. What about the motor nerve? If you're talking about the motor nerve, you will see this is the motor nerve, and motor nerve is supplying a muscle at the floor of the cubital fossa. This is called as supinator muscle. So there is a supinator muscle at the floor of the cubital fossa, and this motor nerve terminal branch of the radial nerve is puncturing supinator and supplying supinator. After that, it will go to the posterior forearm, and there it is called as posterior interosseous nerve. So in the posterior forearm, it is called posterior interosseous nerve. What is it doing there? In the posterior forearm, it is called as the posterior interosseous nerve, supplying the extensor muscle. What extensor muscle it is supplying? Extensor carpus, which is carpus means wrist, so it is causing wrist extension. And then there is extensor digitorum. Digitorum means finger, so it is causing the finger extension. Where? At the MCP joint and also at the IP joint. So you are telling that radial nerve give two terminal branches in the cubital fossa. Yes, this is radial nerve giving two terminal branches in the cubital fossa. And this is the motor nerve, which is puncturing and supplying supinator at the floor of the cubital fossa, and then it is coming to the posterior forearm, and in the posterior forearm it is called posterior interosseous nerve. It's a pure motor nerve, and it is supplying the extensor muscles there. Which extensor muscle it is supplying? It is supplying extensor carpus. Carpus means the wrist, so it is supplying extensor carpus, the wrist, for wrist extension. Yes, and it is also supplying some extensor digitorum muscle, which is for the finger, and finger extension at MCP and also at IP. But I have already mentioned that when you are talking about the IP extension, the IP extension can also be done by lumbrical interossei muscle, because they are inserting on the dorsal distal expansion. So they can also do IP extension. They are supplied by median and ulnar nerve. So since they are supplied by median plus ulnar nerve, it may happen when the radial nerve is injured, the median and ulnar nerve still working, lumbrical interossei still working, inserting on the dorsal distal expansion can still cause IP extension. This you have to remember. And then before you start discussing the patient, you tell me How do you do elbow extension? If I want to do elbow extension, I'll use the triceps. Okay, so triceps, which is working for elbow extension, is actually helped by a small muscle which is called anconeus, and anconeus is helping the triceps for elbow extension. Who is supplying these muscles? Of course, radial nerve. And how the radial nerve supplying these muscles for elbow extension? You see, few branches are given in the axilla to triceps, and few more branches are given in the radial groove. And radial nerve also gives the branch to anconeus in the radial groove. So you're telling that the radial nerve has given some branches to triceps in the axilla and some branches in the radial groove? Yes. And the radial nerve is giving branch to anconeus in the radial groove. You mean to say radial nerve is supplying the two muscles in the radial groove? Yes. And after supplying two muscles in the radial groove for elbow extension, it has come out of the groove and supplying two more muscles. And what are the two more muscles supplying after coming out of the groove? It is supplying the brachioradialis muscle and the ECRL. And what is ECRL? It is a powerful wrist extensor. If you say it is a powerful extensor at the wrist joint, understood. But what is ECRL? See, as the radial nerve came out of the groove, it is supplying two more muscles. One is called brachioradialis and other is called ECRL. ECRL is extensor carpus radial longus. Extensor carpus radial longus. It is a powerful wrist extensor. And what is it doing after that? After that, we already know it is giving two terminal branches. One is cutaneous, one is motor to the posterior forearm, all that. Now, let us discuss the patients. We want to discuss 4 patients now. Patient number 1, 2, 3, and 4. So, you want to discuss 4 patients? Yes, 4 patients. What is your first patient? My first patient is posterior interosseous nerve entrapment injury. Now, if you got a posterior interosseous nerve entrapment injury, what are the clinical features? See, posterior interosseous nerve entrapment injury, we will see the level of injury is here. This is the patient number 1. Yes, that is the patient number 1. So now you are looking at patient number 1. This is the level of injury. Yes, patient number 1, posterior interosseous nerve entrapment injury. So what are the clinical features? The clinical features I can write down. This patient will have, yes, number 1, finger drop. Where? At the MCP joint. So loss of finger extension at the MCP joint? Yes, MCP extension is compromised now. But the IP extension is possible. Why the IP extension possible? Because, you know, it is injury to a branch of radial nerve and the median nerve, ulnar nerve, which is supplying lamina interossei, can still do the IP extension. So IP extension is possible. So MCP extension is gone. Yes. But IP extension possible. Yes. No sensory loss. Why there is no sensory loss? Because this is a pure motor nerve. It's a pure motor nerve, no sensory loss. And no wrist drop. But why there is no wrist drop? Why there is no wrist drop? Because, understand, wherever the nerve is injured, only distal area is involved, not the proximal area. So when this nerve was injured, maybe some extensor carpi muscle are paralyzed and there will be weakness of wrist extension. But wrist extension still working. How? Because whenever the nerve is injured, only distal area involved and the proximal area still working. So the proximal area is still working, then who is still working? Who is still working is ECRL, which is a powerful wrist extensor. So that is why there is no wrist drop. Oh, you are telling this first patient is posterior interosseous nerve entrapment injury and he is having no wrist drop? Yeah, because this injury will affect only extensor carpus and extensor digitorum here, and the proximal area is still working. So you mean to say triceps working? Of course. The brachioradialis is still working? Of course. Sensation of skin on working? Yes. Supinator working? Yes. Okay. So no wrist drop because ECRL working? Yes. Powerful wrist extensor? Yes. Now I have second patient. Patient number 2, it is the supracondylar fracture, which can damage the radial nerve though less often. So there is a case of supracorner fracture which can damage the radial nerve though less often. Mostly it is the median nerve injury, but radial nerve can also be injured in supracorner fracture. Level of injury is here. This is number 2, level of injury. Now if you say this is number 2, level of injury, this is also called as low radial nerve injury. Low radial nerve injury. Now when there is a low radial nerve injury, there can be high radial nerve injury, high radial nerve injury. So high radial nerve injury, high radial nerve injury, this is low radial nerve injury? Yes, because it is just going to terminate. So it is low radial nerve injury. So when there is a low radial nerve injury, will there be a wrist drop? If this is a supracorner fracture patient and maybe less often radial nerve is injured, will there be a wrist drop? No wrist drop. Why no wrist drop? Why there is no wrist drop? Because we have learned wherever the nerve injury is, distal area involved. Maybe sensory loss on the dorsal hand, maybe paralysis of supinator, maybe it is the finger drop at MCP joint, but this will give the wrist drop. Because proximal area working. You mean to say triceps working? Yes. You mean to say brachioradial ECL working? Yes. And because ECL is a powerful wrist extensor, no wrist drop. So this patient also has no wrist drop. Then what is there? What is there is finger drop. Where is finger drop? Of course, finger drop at MCP joint, not the IP joint. Only MCP joint, and there'll be sensory loss. Where the sensory loss? On the dorsum of the hand. So sensory loss on the dorsum of hand, yes, and there'll be weakness of supination. Why there is weak supination? Explain. So you are talking about this second patient, which is supracorner fracture, low radial nerve injury, and he has no wrist drop because is here still working. Yes, and finger drop at MCP because the extensor digitorum compromised. Yes, and sensory loss on the dorsum of the hand because this is the injury, so this cutaneous branch is gone. That is why sensory loss on the dorsum of the hand. Yes, but minus 2.5, 3.5, minus the nail bed, minus the nail bed by median. Okay, weak supination because this supinator is paralyzed. This is the injury, supinator paralyzed. Yes, that is why. Weak supination. Patient number 2. Now we have to look at patient number 3. And when it is fracture mid-shaft humerus, the radial nerve injured in the radial groove. What is this? Patient number 3, fracture mid-shaft humerus, and it is radial nerve injury in the radial groove, lower part of the radial groove. So this is the level number 3 now. Yes, that is level number 3, patient number 3, injury of radial nerve in the radial groove. So now tell me, will there be a wrist drop? Yes, there will be a wrist drop because only triceps will be spared. Only triceps will be spared, and whatever distal to this will be compromised. You mean to say brachioradial is gone? Yes. ECL gone, the powerful wrist extensor? Yes. That is why there is a wrist drop? Yes. Not only wrist drop, there will be also sensory loss on the dorsum of the hand, 2.5 finger, and also weakness of supination, and also finger drop at the MCP joint, but IP extension working. You mean to say this patient has the same problem as this patient, but additional wrist drop? Yes, you can say like that. Patient number 3 has the same features like patient number 2, but wrist drop included. So wrist drop will be there, and finger drop at MCP, and sensory loss on dorsal hand, and weakness supination. Yes, but since this is proximal injury, ECL is gone, wrist drop will be there. Now tell me, will there be injury to branch to Anconius or not? It depends. Sometimes it is involved, sometimes it may not be involved. So understand, fracture mid-shaft humerus, radial nerve injury, radial groove may or may not damage branch to Anconius. Now, even if branch to Anconius is damaged, it does not matter because Anconius is a small muscle and triceps is a large muscle for elbow extension. So elbow extension is still possible in this patient because the injury is distal and the triceps is already supplied in the axilla and in the radial groove. So triceps is spared. If triceps is spared, then who is paralyzed? The ACRL is paralyzed. The supinator is paralyzed. Extensor digitorum paralyzed. But triceps working. And patient number 4 now. As you're talking about the patient number 4, it is crutch palsy. And when you talk about the crutch palsy, you will see now the radial nerve is injured in the axilla itself. See, when you're talking about the 4th patient, which is crutch palsy, there is some patient who is pushing the crutch into axilla and compressing the radial nerve in the axilla itself. Here, this is level number 4. This is the injury. Now you see, even the triceps muscle will be paralyzed. So, elbow extension is gone. So, a question comes. When there's a crutch palsy and radial nerve injury in the axilla, which extension is still working? Because triceps is gone, elbow extension gone. The ECRL is gone, wrist extension gone. The extension term gone, MCP extension gone, but one extension still working, and the answer was interphalangeal extension still working, because crutch palsy, which will damage radial nerve in the axilla, still the median nerve, ulnar nerve working, lumbrical interosseous working, and they will cause interphalangeal extension. So in radial nerve injury, one extension still keep working, interphalangeal extension, because of lumbrical interossei. Now, this is one DNB pattern. This year question, it is asking, nerve supply to supinator is similar to? You mean to say the motor terminal branch of the radial nerve? Yes, motor terminal branch. Extensor digitorum is the answer? Yes, of course. Whoever was supplying supinator is supplying the extensor digitorum. That was the answer. Now, this is a low radial nerve injury. Low radial nerve injury. You mean to say supracorner fracture, low radial nerve injury? Yes. Tell me, what were the clinical features? Patient number 2? Yeah, patient number 2. Tell me, what was the clinical feature? Was there a wrist drop or not? See, when there is a low radial nerve injury, supracorner fracture, radial nerve is injured, but the ECRL was already supplied. So no wrist drop was there. No wrist drop was there. When there is a supracorner fracture, the ECRL is already supplied. So no wrist drop was there. This is a question. See there the question on mid-shaft fracture also. What are mid-shaft fracture? When there is a fracture mid-shaft humerus, then radial nerve injured and there will be a wrist drop. Why? Because radial nerve is compromised. After that, it was supposed to supply ECRL. So is it paralyzed? Yes. And if ECRL paralyzed, there will be wrist drop. So this is a difference. This is patient number 3. That was patient number 3. Fracture mid-shaft humerus, radial nerve injury in radial groove. That will present with wrist drop. Okay. What about crutch palsy? Crutch palsy, the patient is pushing the crutch into axilla and damaging radial nerve at the beginning itself. So elbow extension, gone. Wrist extension, gone. MCF extension, gone. But interphalangeal extension? Still working because lumbrical interossei working. They can do IP extension using ulnar nerve plus median nerve. Now I got a question. It is asking, all are affected in low radial nerve injury, which could be supracorner fracture, except. So it is like second patient, which you have discussed. Patient number 2, yes. Supracorner fracture, yes. Low radial nerve injury, yes. I think ECRL was already supplied. Yes. No wrist drop. No wrist drop. That is your answer. Correct. That is the answer. Keep that answer. And what about this? Injury to radial nerve in the lower part of radial groove, which is something like fracture mid-shaft humerus. I told you fracture mid-shaft humerus may or may not involve branch 2 and coneus, but triceps is always spared and ECRL is always paralyzed. So it is injury to radial nerve in the lower part of radial groove, and coneus may or may not be paralyzed. Triceps is already supplied, it is spared, but ECRL is paralyzed, leading to wrist drop. And what about elbow extension? Still working. So it is asking exception. It is asking some wrong statement here. Yes, it is asking some wrong statement. You have to find the wrong statement. Tell me the wrong statement. I think the wrong statement is this. Yes, you are correct. This is a wrong statement, and that is your answer. It will actually spare the triceps, and it will paralyze the ECRL, leading to wrist drop. It is not sparing ECRL, it will paralyze the ECRL, leading to wrist drop. This is a wrong statement, that is the answer. And Anconius may or may not be paralyzed. It depends upon various patients. And what about the extension? Yeah, triceps is working, so elbow extension is working. No problem with this choice. And supinator is paralyzed? Yes, supinator is paralyzed. That's why weakness of supination. No problem with this choice. Problem is with this choice. This choice is wrong choice because it will spare triceps and paralyze ECRL. So this is a wrong option. This is the answer. There is a wrist drop. There is a paralysis of ECRL. Keep the answer. And you have to give a cock-up splint to the patient who has a radial nerve injury at a high level, because you have to keep the MCP joint into extension, and you have to keep the MCP, this is the wrist joint, that is wrist joint, and MCP joint in the extension. So when there's a wrist drop, you have to keep the wrist in extension and MCP joint in extension. What about the IP? IP, you don't bother. IP, don't bother. So you mean to say I have to give a cock-up splint which is working at wrist joint? Yes. And MCP, the knuckle joint? Yes. And IP, you don't bother? IP can be in flexion. Yeah, that doesn't matter because the IP extension can still be working with the help of lumbrical interosseous. Your focus will remain on the wrist extension and the MCP extension. That is what you have to extend, cock-up splint. Cock-up splint. In a case of radial nerve injury, high radial nerve injury, till the nerve is regenerating, you have to keep it in this posture.